my pleasure to speak today about the GTFRCC investment framework, which was spearheaded by Dr. Rifat Attoun from the Harvard School of Public Health. And this was really a scientific and data-driven approach to creating change in healthcare by integrating the information of the working groups into an organizing framework that could be used by policymakers. Many of us in high-income countries, at least, are familiar with one story of radiotherapy. We know it to be the standard of care in half of all malignancies. We know that it's effective for cure and palliation of symptoms. And we have, generally speaking, widespread availability in high-income countries. And the current focus is on improving utilization. And there are many new technological and clinical advances on the horizon. But as David showed on the map by the International Atomic Energy Agency on the number of radiotherapy machines per million people, there is another story of radiotherapy where we see many countries around the world having no machines or less than one machine, which may or may not be operational. And this is the story of no radiotherapy. There are tragic consequences to this gap in access. Not only are cancer patients deprived of the possibility of curative treatment and are more likely to die of their disease, but they also have no access to palliative radiotherapy to relieve pain and other symptoms. They may receive care in palliative care units such as this one in Malawi, which was funded through the Diana Princess of Wales Foundation. And although this unit provides compassionate care, patients in it have no access to radiotherapy to relieve symptoms related to local or distant metastases. So how do we create one story, the story of universal access to high-quality radiotherapy? Medical evidence is often not enough to improve access to radiotherapy. There are many competing needs in healthcare and in other underserviced sectors, in education, infrastructure, agriculture, that are all competing for scarce resources. There are often powerful lobby groups and political dynamics that determine which programs get funded, and policymakers often have limited access to information on cost, demand, and value. And so perhaps we need a new frame of reference to examine different kinds of evidence, those of health systems, those of economics, as well as traditional medical evidence. We need to examine and link multiple kinds of evidence and present them in a way that is meaningful to decision makers. The investment framework that we used is a quantitative framework that illustrates the bidirectionality of spending on health and economic growth. And it is a platform to compare competing health priorities over a long time horizon to guide future spending. There is proven success worldwide of such an investment framework approach. Global modeling projections of costs and benefits of strategic investments in HIV/AIDS, tuberculosis, and malaria led to the creation in 2002 of the Global Fund, which since its inception has saved 15 million lives and prevented 140 to 180 million new infections since 2012. In 2016, there were 7.3 million people alive on antiretroviral therapy, 4.6 million people on direct observed therapy, and 90 million insecticidal nets distributed. In 2013, a Lancet commission called Global Health 2035 revisited the case for investment in health and developed a new investment framework to achieve dramatic health gains by 2035 within a generation. And they made several points. They said that there is enormous payoff from improvements in health, that fiscal policies are a powerful and underused lever to curb non-communicable diseases and injuries, that progressive pathways to universal health coverage are an efficient way to achieve health and financial protection, and that a grand convergence is achievable in our lifetime, that we collectively have the financial and technical capacity to reduce rates of infectious child and maternal mortality to low levels by 2035 to achieve this grand convergence in health. And so can we apply this approach to radiotherapy? To do this, the GTFRCC needed a way to link the different pieces of information that David presented on the cost and on the benefits. And so we developed cancer site-specific models to simulate the lifetime following a cancer diagnosis. And we modeled a phased radiotherapy investment scenario over a 20-year incidence period and compared it to the status quo. We modeled what happens if you slowly and incrementally increase radiotherapy capacity over a 20-year period such that by 2035, everyone who needs radiotherapy has access to it. And there were a few different model outcomes. The first was the life years gained from such an investment. And the second was the net monetary benefits. What was the impact on the economy by providing access to radiotherapy? And we used two different approaches to measure the net monetary benefits. The first was called a human capital approach, and this looks at the benefit from labor force participation and productivity as a result of deaths avoided from cancer. And it's calculated as the increase in GDP achieved through each additional life year gained. The second is a full income or value of life years approach. And this is a method of quantifying the monetary value or trade-offs of living a longer life. And it refers to the ratio of wealth people are willing to spend in exchange for a reduction in the probability of death, which we express as a dollar value. And of course, this is different in different parts of the world, and we drew on the values calculated by the Lancet Global Health 2035 Commission for low and middle income countries. There are a number of assumptions that are embedded in this model, and they are presented in greater detail in the Lancet Oncology publication. We had assumptions around cancer incidence projections out to 2035, the number of cases needing radiotherapy, the population survival benefit, and the infrastructure and operational costs. These are all inputs that went into the model. There's other health system requirements that are needed, and these are described in the report, although these are not quantified in our model. And the costs and benefits were discounted by 3% over a lifetime horizon as is standard practice. So turning to the results, the global expansion of radiotherapy clearly brings immense health benefits. Over the 20-year period with such an investment, we see that 26.9 million life years are saved across low and middle income countries. And there are some differences between the low income, lower middle, and upper middle income countries, and these are largely due to differences in cancer incidence, age of diagnosis, competing risks of death, and the age structure of the population. And using those cost per fraction that David presented, the cost of global expansion of radiotherapy using the nominal model totals $184 billion, and using an efficiency model totals nearly $97 billion across low and middle income countries. And these seem like very big numbers, and so it's important to put them in the context of the benefit. Using the human capital approach, we have a return on our investment of nearly $17 billion with the nominal cost model and over $100 billion with the efficiency model. And we see that very quickly, the benefits quickly outpace the costs. And those benefits are even greater when we look at the full income approach, where we see that almost immediately the economic impact on the country is enormous, that the benefits of putting people back to work and allowing them to contribute to the economy creates immediate economic benefits. And the slope of these curves may be different in places that have different infrastructure or human resource barriers and different capacity for scale-up. And so through the investment framework, we've been able to connect benefits, demand, and cost to demonstrate value. But clearly there are many other factors that impact investment in health. They include appropriate financing models, medical community action, health system strengthening, transformational leadership, public awareness, and grassroots mobilization. But looking at the GTFRCC results, we see that significant health and economic benefits can be achieved from increasing access to radiotherapy in developing countries. And that by connecting need, value, and cost, we can heighten the motivation for investment and innovation. And the results of the GTFRCC provide an important platform for advocacy and international cooperation to address this pressing global health problem.